Welcome to Your Health this Wednesday morning, and today's discussion will be focused on patient safety at the backdrop of the Kenyatta National Hospital saga. But before we get to that, let's get to the news on health with me, Dr. Mercy Korir. And now most cancer patients are unable to afford the high cost of treatment since majority live below the poverty line. The situation is worsened by the few public hospitals which lack the financial muscle to treat cancer. Hence, patients prefer to take the cheapest but improper treatment. Our crew recently visited some of the patients undergoing such turmoils and reports their agony.
Doreen Owor sits helpless at her bed at the Rift Valley Provincial General Hospital. She has been admitted here several times. The cervical cancer she was diagnosed with 3 years ago has strangled every bit of her energy, choking her otherwise well-being, and as a result, she has lost a lot of weight. The widow has to now rely on assistance from nurses at the hospital to do what would otherwise be considered an easy activity by a healthy human being. Doreen is not alone. Tales of patients diagnosed with cancerous cells at the hospital is heartbreaking. 72-year-old Mary Wangoi is a breast cancer patient. She has to sit for hours at the corridors of this palliative care unit in the hospital, waiting for a prescription of painkillers to relieve her endless pain, the only medical care she can afford.
Mimi nakuja kwa huyu ananiandikia dawa. Mimi naenda chukua dawa ya uchungu sababu ana uwezo ya kuninunulia dawa hiyo kubwa hivi.
Despite being diagnosed with the disease 6 years ago, she has not commenced proper treatment. The disease has left her financially burdened and not able to care for her 6 children. The hospital is incapable of treating advanced stages of cancer, and patients who come here receive blood transfusion services or get pain-relieving tablets.
Some of them to get transport to go is an issue. Some of them will get transport, but sometimes what is asked for later, do this test, do that, bring this, we need this, may be also a very big challenge for them.
Those who come here with serious cancer stages are referred to more progressive hospitals, which they never end up visiting because they are far and unaffordable.
Sometimes you get even a patient who still has the disease maybe has not gone too far. And with that rebooking and, that long period of booking actually worsens the situation.
Mary Chepkoech is another such patient. The expensive treatment has drained her pockets, and according to her, the best treatment she can get is a blood transfusion, which is also hard to come by due to shortage of blood banks in this hospital.
Pesa ikakuwa mingi zaidi na ujue walivisha ndio ananisaidia. Sasa sikuweza kuendelea tena na matibabu ya kansa.
The 3 patients are an example of hundreds of others who are going through pain and have to survive on the available but wrong treatment and are not able to seek proper treatment at the referral hospitals in the country. Caroline B., KTN News.
What a tragic pain for cancer. Now we go to Argentina, where more than 70 Argentine lawmakers of several political parties presented a bill Tuesday to legalize elective abortion in the first 14 weeks of pregnancy. Now, most lawmakers wore green handkerchiefs symbolizing the abortion rights movement as the measure was introduced to chairs. Abortion is only allowed in Argentina in cases of rape and risks to a woman's health, but advocates say that doctors and judges often continue to block therapeutic abortions despite a 2012 Supreme Court ruling that was supposed to remove barriers and take judges out of such decisions. Legislative efforts to allow elective abortions have failed in the past, but the new initiative has wider backing. 9 people have appeared in a Benin court on charges of selling fake drugs at the start of a landmark trial in a regional campaign against illicit medicines. The suspects, who include executives from major pharmaceutical companies operating in the West African nation, were remanded in custody until March 6th on technical grounds. Benin launched the crackdown last year after mounting alarm about the scale of the trafficking of expired and counterfeit drugs in West Africa. Fake medicines are drugs that are bogus or below regulatory standards, but often are outwardly wrong. Now we go to South Africa, where the South African government has blamed a lack of cooperation by producers of cold meats for a delay in finding a cause for a listeria outbreak that has killed 180 people in the past year. The government, which has been criticized for taking too long to find the source of the disease, on Sunday linked the outbreak to a meat product known as polony, made by Tiger Unit Enterprise Food. It also said it was investigating an RCL plant. South Africa's health ministry said the source of the outbreak was found after preschool children fell ill from eating polony products traced to processed meat producers. Now, in a reaction to that story from South Africa, Kenya has banned the importation and sale of processed meat products from South Africa after the listeria outbreak was traced to ready-to-eat meat. The Ministry of Health has also recalled all the products that are already in the market, asking retailers not to put them up for sale. Kenya now joins Namibia, Mozambique, Malawi, Botswana, and Zambia have followed suit in suspending the importation. Now, to a story that will lead to the topic of discussion today on your health, where consultant doctors from the Kenyatta National Hospital have threatened to withdraw their services if staffing issues at the hospital are not addressed urgently. The withdrawal of services by resident doctors and lecturers has started crippling the treatment of thousands of patients at the facility.
Early morning at the country's leading referral hospital, the shortage of health personnel here forces these visitors to carry their patients to the stretchers. They are not the only ones. Today is a bad day to seek treatment. Over 700 registrars boycotted work Monday in defense of their colleague who was suspended for the surgery mix-up. 39-year-old Josiah Ndimuli has come to seek treatment for his 10-year-old son, but the delay is killing his patients.
Ile shida imenileta hapa ni ugonjwa wa mtoto. Juu mtoto nimegwachana Mbakadi, nikatumwa Kenyatta. Sasa Kenyatta kwenyewe nimekuja kutoka saa 1 mpaka saa hii mimi sijahudumiwa.
His son is suffering from a skin condition, and up till 12 noon, the children's clinic he was visiting was full, with very few doctors in sight to assist him.
Wale watu walikundua mtoto akona shida walikuwa walimu. Juu mtoto mimi ndio nakaa naye peke yangu. Huyo mtoto wakati alienda shule ikapatikana akona shida ya masikio. Akona shida hii mikono, ukiangalia mikono yake imechikunja. Akitembea anatembea na saidi moja.
Registrars, essentially senior student doctors on further training, are not the only doctors on strike in all the referral hospitals in the country. Their dons too downed their tools 2 weeks ago until their emergency and risk allowance are paid, further worsening the failing situation. Consultant doctors are among the few left to attend to numerous patients. Despite objecting to suspension of the surgeon, they admitted to such glitches occurring, but suggested proper measures to be taken to solve the issue. They further want the staffing ratio at the hospital addressed.
As we talk, now that they have withdrawn their services and we are running with a skeletal staff of only 15%, we will just be forced to withdraw elective clinics. We will be forced to withdraw elective theatres because we cannot handle the emergencies that come to Kenyatta.
We also appeal the University of Nairobi to come up and build its own teaching hospital so that Kenyatta National Hospital can employ its own doctors and stop over-relying on the residents.
The Kenya Medical Practitioners, Pharmacist and Dentist Union has also issued an ultimatum to the Kenyatta National Hospital to sign their recognition agreement.
And we want to tell the management that KMBDO is issuing you with a notice. In the next 7 days, you have to sign a recognition agreement.
For patients like Josiah, should the situation continue this way, it pronounces harsh times for them.
Sina venye nitafanya, sasa nitafanya aje na mimi nilikuwa nimekuja daktari anionee mtoto.
Caroline B, KTN News.
Now, that's the focus of our discussion today, because throughout the healthcare industry, the failure to correctly identify patients continues to result in medication errors, transfusion errors, testing errors, wrong person procedures, and even the discharge of infants to the wrong families. There is a high risk of patient misidentification due to name structure, close similarity of names, and inaccuracies in birth dates, especially for elderly patients. The major areas where patient misidentification can occur include drug administration, phlebotomy, which is drawing of blood for tests, blood transfusions and surgical interventions, as was witnessed at the Kenyatta National Hospital. An increased number of team members caring for each patient thereby increase the likelihood of handover and other communication problems that may put patients at risk. There are protocols and standard operating procedures to safeguard the patient's safety in any health facility. But are they working? That is the focus this morning. And with me for this discussion, to my immediate left is Dr. Timothy Panga. Dr. Panga is a clinical pharmacist. Next to Dr. Timothy is Halima Adan, who is a perioperative nurse, or simply put, she is a specialist theatre nurse. And last but not least is Dr. Abdi Mohamed, who is the chair of the Kenya Association of Private Hospitals and also the chief executive officer of Metropolitan Hospital. And we'll go straight into that discussion. And I'd like to start with Halima, since this was a surgical intervention. Are the protocols that have been put in place working? And if so, what are these protocols?
We have several protocols that are put in place for safety of patients and health workers also. But as much as we would want them to work, I would say they are not working, because we are facing several challenges, especially in the health facilities for shortage of staff, where you're having the patient to health workers ratio is so low. Counties are not employing anymore. The national government is not employing. You're finding, for example, for the doctors, we have a shortage of doctors in this country. So in some hospitals, you'd find we don't have specialists. I would give an example of where a hospital that doesn't have an orthopedic surgeon. So a general surgeon is converted to do orthopedic surgeries. That in itself is breach of protocol. Then for nurses, you have a ratio of 1 nurse to 40 patients. In an ideal situation in theatre, we're supposed to have 5 nurses per shift, 1 handling administration and management, another one handling patients post-operatively, and intraoperatively we have a circulating nurse, we have a scrub nurse, and we have now a nurse who is taking care of that operating room to ensure that everything is being followed. But currently, you'll find 1 or 2 nurses. So what happens? We have patients, and all patients are waiting for that day for surgery, about 8 or 10. You have to do all of them. So most of the time, these nurses are fatigued. So as much as they want to follow the standard operating procedures, they'll do their best to follow that. But most of the times, you're the one receiving a patient from the ward, and you're the only other nurse that is supposed to take care of a patient who has just come out of theatre and hand over that patient to the ward nurse. So it's a bit difficult, but we are doing our best. But the systems have failed us in terms of employment of more staff to ensure that at least we are able to offer the basic services and we are able to follow protocols.
Okay. So the issue, in your opinion, is on the staffing levels?
Yes,
of the
staffing levels.
Dr. Abdi, do you agree? Or in your opinion, have these protocols failed us in another aspect or in another way?
Actually, what we are trying to say is a pilot to be the pilot of the aeroplane and at the same time to be the cabin crew. So you can imagine flying a plane and at the same time serving tea to your passengers. That's exactly what we are trying to tell healthcare workers in this country, and it's not possible. It can't work. What she's talking about, the ratios, basically is saying for each thing to be done, there must be enough people to do it. Otherwise, you can't multitask and do both of them at the same time. And for quality healthcare, you have to invest in literally everything that needs to be invested in, from staffing, from the equipment, from the supplies, literally everything must be in order for a system to work. But the moment you have certain parts of that system missing, then it's difficult to make it work. As for what happened in KNH, it's unfortunate. We are sorry to the families and the staff who are involved, because those are people who reported that a mistake has happened. Actually, that's something that should be applauded, and it's something that's expected normally in any setting where mistakes happen and people correct them. But the challenge in this country is we jump. There are 1,001 other mistakes that are happening every day in hospitals that people are not aware. One mistake does not mean that we should vilify the people who are involved. But as I said, it's not possible to work where there are people who are missing to work. And it's unfortunate. That's where we are. Okay, thank you.
Dr. Panga, you're an advocate of patient safety. Do you agree with our colleagues?
I partially agree, yes, to that extent of saying there could be inadequate numbers of staff and resources. But if you look at this issue of patient safety worldwide, even the best resourced, best staffed, highest skilled healthcare systems still have errors and still have increasing focus on patient safety. And that tells you one thing, that the direction in which healthcare workers should take in their training, in their orientations, should actually be towards increasing their own awareness that they are likely to provide unsafe care and mitigate the effects of the potential and intended and the harm of the patients coming from you not intending to provide unsafe care. And the focus should actually be, what are our priorities in terms of patient safety? You must start from somewhere. Do we have patient safety goals which we aim at? Do we have we allowed ourselves to have a culture where we do not blame because culture of blame is known internationally to actually hamper patient safety. So my view is actually there should be more collaboration among health workers. Health is a very big enterprise with very large number of people from wide specialties, all of them trying to communicate to each other. Can we improve communication? That's actually one of the international patient safety goals. Can we identify patients safely? That is another goal. Can we reduce the harm of high alert medications? And that's where really I come in as a pharmacist. Can we have safe surgeries? Can we reduce incidence of healthcare associated infections? Do we do risk assessment for falls for every patient to come in the wards? Those are the kind of issues we need to address wholesomely so that we can have a safe culture.
Okay. For us to understand what these goals are, I would like, since you are practicing healthcare workers, just to explain to the public what are, like, in before surgery, during surgery, and post-surgery, what are the protocols to ensure patient safety so that the public can understand? And I'd like to invite the public to just get in touch with us. Tell us if you have experienced any kind of mishap or what experience you've undergone when you're seeking healthcare services. And you can get in touch through our lines, through our SMS, and also on Twitter. You can get in touch with us at KTN News, or you can tweet me directly at Dr. Mercy Korir, and we'll be able to engage you, and my panel here will be able to respond to some of your queries and some of your experiences that you've undergone at the healthcare facility. So I'd like to come to you, Halima. What are the ideal standard operating procedures to ensure patient safety before, during, and after surgery, so that people know what is ideal and what is actually happening, keeping in mind all the issues that the three of you have raised?
Thank you, Dr. Mercy. First of all, before a patient comes to theatre, we usually have two categories of patients, an emergency patient and an elective patient. For an emergency patient, that's a patient that is supposed to get into theatre in the shortest time possible. So I'll explain for the elective patient, because at least we have some time to prepare this patient. In an ideal situation, the team from theatre, including the nurses, the anesthetist, and the surgeon operating on these patients, are supposed to visit this patient a day before, just to familiarize and know the patient, and do history taking, do a physical examination to determine if there are any risks involved in their own line. If it's the anesthetist, is there any risks involved during anesthesia? If it's a nurse, is there any risks involved when you're giving nursing care to this patient in theatre? And the surgeon, their own line, when they're operating, what are their expectations? Once you do that, you have already introduced yourself to this patient, and the patient knows that there's something, you have prepared this patient psychologically. So once everything is okay, there's a responsibility by the team in the ward also, which includes investigations, blood investigations, some preparations done by nurses. So this is highlighted for this patient in the file, in their own personal file. So once all this is done, the patient now comes the following day to theatre, ready, and they are already familiar with the people that they are going to meet. At the entrance in theatre, the ward nurse is supposed to hand over this patient with an identification band and to give the history and any special issues with the patient to this nurse who is receiving the patient. At the receiving end, there's supposed to be an anesthetist and the nurse and the surgeon. We have a WHO checklist that ensures safety for, it's actually a safety checklist where you need to counter check, is this the right patient for this procedure? Does the notes, the name, and the history tally with the patient? Then inside, before you start the surgery, there is also in the same checklist something that you're supposed to check. One, the team introduces themselves to the patient. Once you do that, everyone airs out their issues in case there are any expectations, blood loss. The nurse talks about the sterility for the set. In a nutshell, it's supposed to be teamwork because everyone depends on the other for the success story of this patient. So for us to have a good outcome, we must all work as a team, and the communication for this patient should be done in a way that this patient is hearing. Now, we have these other special patients who are unconscious,
And they cannot identify themselves. They don't even know who their healthcare providers are.
Yes, they even come in being known as a known African man and known African woman. Now, for such, due diligence must be followed. We must be very careful. And I was reading somewhere, and for the nurses especially, we play a very critical role because we are with the patient 24 hours. We are the people who are with these patients most of the time, probably first contact, last contact. Last contact going home, going elsewhere. So we must be very careful. And when I talked of shortage of staff, as you do allocations for these nurses, as a manager in a unit, whether a ward or a theatre, you need to really look at what nurses do you have? What skills do they possess? How old are they? Are they having any medical conditions that would hinder their operations on the day-to-day activities? So nurses who are almost going on retire with hypertension because of poor pay in this country, they are frustrated. As nurses recently, we were asking for risk allowance. It was not given to us. But when something like this happens, we are the first ones to go to jail.
Okay, we'll come back and discuss the issues of staffing. But before we get to that, and I would also like us to go through just the scenario of an emergency patient, because you've taken us through an elective patient where everyone has time to prepare for this patient. So in case of an emergency, what are the protocols? What are the standard operating procedures? And I'll throw this to Dr. Abdi immediately after the break. And when we come back from break, we'd like you to engage with us. And we're asking you, what has been your experience in seeking healthcare services? And we are focusing on the mishap that has happened at the Kenyatta National Hospital or that may have happened in any other facility. We'd like to hear from you. So you can give us a call or you can tweet us at KTN News or at me directly at Dr. Mercy Korir. And when we come back, we'll be able to engage with you. Our phone lines are on, and we'll take a break. And when we come back, we shall continue with this discussion on patient safety.